is a case of a 45-year-old male who sustained a type C pilon fracture. You can see this is the type where the fibula remains intact. Having his ankle spanned with a monolateral external fixator, his plafond was then scanned. You can see that there is a combination of distal tibial intra-articular fracture and a talar dome injury as well. Here is the talar dome injury that you can see. He went on to have open reduction internal fixation with a posterior, anterolateral and a medial plate. See, however, that the articular surfaces from the posterolateral and the anterolateral fragments are not really married up. He came to see me some 4 months after the original injury and the subsequent fixation. He was told by various other surgeons that probably the best way forward would be to mobilise, rehabilitate and then fuse his ankle later. He was desperate to try and maintain his ankle, and to this effect he actually had not started bearing load through his foot in a way to try and stop the articular incongruity causing arthritis. And here I want to talk you through how I went about trying to revise this chap's fixation. In the first instance, I removed all of the metalwork and I used some local beads here to place local antibiotics into the areas, into the soft tissue defects left behind from removal of the metalwork. Here you can see the incongruity of the articular surface, which is much more clearly visualized. Talar dome is congruent with the anterior and incongruent with the posterior fragment. So the talar dome, the talus is being spat out here from the front of the ankle. I then actually placed him inside a distraction frame. So this is a circular frame. You can see that there are hinges here. So this is a hinge and this is another hinge on either side of the ankle joint in line with the center of rotation of the talus. And in order to both distract the ankle joint that you can see here, but also try and bring the talar dome more posteriorly in order to try and reduce it when you compare it to the position of the talar dome in relation to the posterior malleolus here. This is what it looks like. You can see the proximal ring, which is up here, and a single ring, which you can see across here, across the foot. The ankle is spanned and it is distracted. The hinges on either side, which you can see here, and another one is sort of amongst the metalwork there. It allows the individual two things. One, he's able to bear load so that the foot starts accepting load again through it, and the other thing is to try and improve the range of movement of the ankle by unlocking these struts here at the front. He's able to dorsiflex and plantarflex his ankle in order to regain range of movement. I rescanned him in order to see the shape of the abnormality in the articular incongruity. Once we had proved that there is no infection, and I now had a very clear idea of the anatomy of this articular incongruity, here I have used an ACL jig in order to identify where I want my intra-articular osteotomy to come out. And here we are. The tip of the jig is inside the articular incongruity, and then subsequently use an osteotome to perform the intra-articular osteotomy. Then I can use a buttress plate. You can see this Y plate now, this Y plate on the medial side to allow both the anterolateral and the anteromedial points to be buttressed and the fragment brought down to articular congruence. So here we are. You can see the position of the plates, and actually here you can see that the articular surface of the talus is quite nicely preserved. Here is the CT scans. You can see here these are the wires from the external fixator. So I maintained the presence of the external fixator for a further 8 weeks or so till we had union of the intra-articular osteotomy. This also allowed the ankle to continue movement, and much like you do for ankle distraction, it allowed recovery of the articular cartilage. And here are the radiographs at 6 months post removal of the frame. He has a very good range of movement of the ankle. He's now back jogging. The thing to note, however, is that you can see that there is effacement of the articular surface. You can see that the tibio-talar, compared to some of the other on the medial and the lateral side, there is a reduction in the articular space, but the congruity of the ankle joint has been restored, and hopefully he will avoid an ankle fusion or further destructive surgeries for his ankle arthritis.